Hey guys, you ever thought about where is the future of dental sleep medicine going? I mean, it's a really hot topic. And so, where is this conversation headed? And what are some of the new things that are on the horizon in dentistry and with the ADA? Well, if you ever asked that question, I've got the man with the answers today, and you don't want to miss this. So, stick around, grab a pen, and hit the share button. You're going to love this. Hey guys, welcome back to the Best Practices Show. My name is Kirk Behrendt, and I am your host today. And I want to just thank you for showing up because you're going to hear about something that's really special in dentistry from a great friend and a great educator, Dr. Steve Carstensen. And he is a sharp guy. And you're going to love this conversation because dental sleep medicine is not going away. Airway is critically important, and dentists are better positioned to really help people be healthy for a long time. And you're going to have to know what they're all talking about. And we're going to be talking about what the future holds in that respect in dentistry. Now, if you're just joining us for the first time, as a lot of young dentists are, I just want to encourage you. Well, first of all, I want to say thank you for showing up. And then secondly, I just want to welcome you to a very inviting community where, hey, we're just about learning here. And I want to encourage you to do one thing. If you're listening on Spotify or Stitcher or iTunes, I don't care where you listen to audio podcasts. It's funny because we do all these videos and you guys never watch them, but you listen to the audios, which I'm totally cool with. Do me a favor, just flip up your phone. Well, actually, don't flip up your phone. There's no flip phone. Go down to the subscribe button and just hit the subscribe button because I want you to show up with us every single week because you're going to see every single week I'm going to bring you a brand new expert in dentistry, and I don't want you to miss out. And all they're going to do is share best practices so you can have a better practice and a better life. So make sure you do that. Also, if you haven't joined our Facebook group, our private Facebook group, it's called Best Practices, powered by Act Dental. Check it out. We're over 13,000 of you have joined just as an opportunity to be part of a community that's just helping each other. So you're really going to enjoy that. So make sure you check it out. And then lastly, if you run a dental practice and you're thinking, gosh, it's been great, but I know it could be better, check out actdental.com where you can see not only actdentalu.com, which it helps you improve your practice. You're going to see every single week we have a master class and we've got great resources over there. We're a practice coaching company. So if you're wondering, how can I improve my practice? Give us a call. We're happy to help you. I'm even happy to listen to associates. I love talking to young associates because they always wonder, how can I do this? Can I do this? Can I do it on my own? Absolutely. You get one shot at this thing called life, but if you do it right, it's all you need. Now, I want to introduce my guest, Steve. I've known you for a long time, and
Yeah.
you've been a great friend, great educator. You're part, I got to know you through the Pankey Institute, speaking on the road, and now you're part of Spear Education and just a greater community of great teachers. And I know you've got a huge meeting coming up on Thursday, but I want people to know who you are if they've never met you before. So, who's Dr. Steve Carstensen?
Well, first thing I want to say is listening to your intro, Kirk, I don't understand why people don't watch you online. You're not near as scary looking as people say. So,
It's kind of you.
so my background is in 1983, 98, when I graduated from dental school, I said, I don't want to be average. How do I not be average? So I knew I was going to be a long time learner. And I found the Pankey Institute early on, and that became home for me for learning. And really interesting, Kirk, is the second time I was at Pankey for C2 back in the day, my lead faculty was Keith Thornton. And so as I grew as a dentist and I became a restorative dentist, Keith was always kind of talking to me about airway issues. And in the late 90s, it became a real popular thing. And I started doing airway appliances for patients and learning more and learning more. And my general practice was going on and my airway practice was going on. And I was teaching and helping to run meetings at the Pacific Northwest Dental Conference here in Seattle, and started working with the ADA in 2007. They invited me to be on the council for the annual session. So this is like the culmination of my dental career, as I could help formulate the ADA's meeting. Well, wow, what an honor. I found out I really liked educating, and I really liked thinking about how much dentists could impact their community health through what they learned. So as they gained knowledge and gained skills from educators like me and like all the other great ones out there, the ones you've had on your program, the other ones, then it's really not just about what they learn. It's really what they could do to help their community.
Right.
So working with the ADA was fantastic. So my practice was growing, and about 5.5, 6 years ago now, I was realizing, wow, I don't have enough space in my practice to take care of all the restorative needs that my patients have. And I don't have enough space in my practice to take care of all the airway patients that are being sent my way. And I thought, well, I can't do both. And my little office wasn't big enough for an associate. So what I decided to do with a woman across the street is we both sold our general practices and started our own dental sleep medicine practice, TMD issue practice in Bellevue. And that's all we've done now for coming up on 6 years. Meanwhile, educating, that's all I teach about now is airway issues and how dentists can make a difference. Meanwhile, I've been in part of the ADA's education effort, and because of that, also advocating for what dentists are able to do. I was part of leadership with American Academy of Dental Sleep Medicine. I've been part of the AASM. I'm on a task force for what dentists can do together with the American Academy of Sleep Medicine, the sleep docs. I teach at Pankey, I teach at Spear, I teach at conferences all over, I teach for Seattle Study Club. It's really, my whole life is to make sure that people breathe better every night, and actually over their whole lives. So it's kind of a 4D thing, Kirk. It's 3 dimensions of airway that we all learn about in an anatomy class in dental school, plus the 4th dimension of how does it affect their lives from their infancy all the way to, their old age. And dentists have an amazing and really rewarding way to make a difference in all that. So that's energizing for me. I love to talk about it. I love to help dentists realize what they can do differently.
That's awesome. That's awesome. Now, I want to do 2 things. I want to talk about the why of why dental sleep medicine is such an important conversation. And then I also want you to talk about this Thursday is one of the largest meetings of your life, and it's very important for dentistry. Can you put those 2 conversations together? Because this has been a pretty big project up to this point on Thursday, right?
Oh gosh, yeah. How do I weave this story, Kirk? It's going to be the thing is that treating adults for sleep apnea is a pretty settled thing. We'll talk about a little bit more about that. And Mark Murphy did a great job telling you a lot about that over the last few weeks. But treating adults is pretty much, settled. But what's really different is what we can do for children. And the policy statement, I'll tell more about that. The policy statement in 2018 that the ADA passed, 2017, sorry, had a paragraph about kids. And that sparked off an effort to define what dentists can do for little kids, because we do things differently for kids than we do for adults. It's critical that we know that. Well, what's true though is if you go to any dental practice, any school nurse, any pediatric practice, any pediatrician practice, and you wonder, well, what's different? How do we tell which kids need help and which kids don't? Well, we have screeners, right? That's how we identify people at risk for different problems and send them off into diagnosis. Well, screeners that we look at for kids, currently, the ones that are validated, that really have some science behind them, they were made for populations of kids that are, already kind of screened. They're already in some office that knows about airway issues. But what can their everyday dentists do to make it part of their everyday practice? Kind of like what we do for oral cancer screening. How can we screen little kids? There wasn't a tool for that. So the 2018, we had a conference in Chicago, that hosted 30 or so luminaries of dental sleep medicine, of children's airway, of growth and development, of myofunction. All these wonderful people came to Chicago, and we created a task force to develop a new screener. This was a volunteer effort, just a bunch of passionate people saying, well, yeah, we could do that. Then in 2019, ADA came along and said, well, let's make this important. Let's mandate this. Let's put it in the hands of the Council on Dental Practice. That's the part of the ADA, the volunteer council, plus the experts in Chicago that help guide what we do every day in dentistry. They create guidelines, they work with the legislatures, they do all the cool stuff. So the Council on Dental Practice now has a mandate to form this new screener. They knew that the task force from the 2018 meeting, we called it CAST, Children's Airway Screener Task Force, CAST, who had been working on a screener just as an ad hoc group of volunteers. So they reached out to us, the Council on Dental Practice, and said, we'd like to take your screener and use it to fulfill our ADA mandate to come up with a new screener. And of course, we all had this in mind. This wasn't a mystery. This wasn't a surprise. So we did that. Well, what happens on Thursday, Kirk, is that the Council on Dental Practice's subcommittee for this area is going to hear our pitch. 3 years of work. We have some people working on this new screener tool, and the subcommittee is going to take our proposal and put it up to the Council on Dental Practice as an official, this is what we should do as an ADA. Well, now that moves the work that's being done by this group of passionate volunteers, headed by a sleep physician, populated by another sleep physician researcher from Harvard, and myofunctional therapists and orthodontists and a bunch of great people. They've been working so hard, this cast, to come up with a new screener. Now the ADA is going to get behind it and say, that's no longer just a group of volunteers that have ad hoc put this together. This is actually going to be an effort of the American Dental Association. That stamp of approval right there is what we've been working for, because when that happens, that opens up the door for us to validate the study, to make sure it's going to be effective, and then we can roll it out to every dental practice. And then the workflow, the families coming into practice within 3 minutes can be separated which kids are at risk for breathing problems and which kids are just fine.
Right.
Yeah.
And it marks a big day. You know, we've been in this conversation for a while, but Steve, help people understand why it's been so difficult to get to this point. Like, why is it?
Well, we think about screeners and we think, well, how easy is it for somebody to say yes or no to some questions on a form? We do that all the time. But, in medical world and in scientific world, there's actually a big process behind that, Kirk. And this is a bunch of learning I've been doing, that if you ask a question about a health issue, there's got to be scientific reason why you asked the question, and it's got to lead that the patient, the person, into this pathway or that pathway, depending on the answer to the question. And that's actually a big scientific deal. Who knew? And so we have 5 questions we're going to be asking, and so we have to do a lot of validation. So if the American Dental Association is going to roll out a screener, instead of just making up 5 questions and thinking, okay, these must be important because we think they are, we're actually going to have scientists and researchers, and there's a PhD, a periodontist with a PhD in medical science, informatics, is going to help us. And we're going to make this an unkillable tool for anybody to use. So the ADA will now have the world's best tool for identifying children at risk for breathing problems. That's a powerful thing, because it takes that out of the hands of, well, I think they breathe okay, into something that's really important.
Right. And I don't think anyone would debate how important this is, but you hear these questions all the time. I talk to young dentists and they're like, yeah, but I don't know how to put it into my practice. I don't know how to make money. And now we'll have more of a standardization around how we have those conversations. And here's one of my questions that you and I didn't talk about. Of all the dentists in the United States, what percentage of them have incorporated even a little bit of dental sleep medicine? Is there any guess on that?
Well, the best guess we have is when I talk to manufacturers and I say, well, how many people are doing and that use your tool? your device. And I work with Airway Technologies and help teach about tap appliances, for example. So I kind of know how many dentists are doing that. There's a few thousand of us. The key is there's 163,000 practicing dentists. There's only a few thousand practicing physicians. And out of those few thousand practicing sleep physicians, there's only a few hundred, maybe not even 200, that are practicing pediatric sleep medicine. Because the biggest difference is for adults is we manage airways completely differently for kids, for adults and kids. So the sleep physicians don't really have a ton of tools to work with little kids. Plus the problems are different. So our screener tool is going to be aimed at identifying those problems. What's going south about these kids' health and behavior and issues every day, every night, that we can intervene as dentists. Because actually, Kirk, we're the ones going to be in charge of fixing the problems that we are identifying. Once a child has been screened and once we identify kind of what is wrong here, then it's really dentists that can make the difference, because we know about growth and development of the lower third of the face. What my friend Dr. Boyd from Chicago calls the craniofacial respiratory complex. The perfect definition with too long of words. I tell Kevin, craniofacial respiratory complex. It's the growth and development of the maxilla and the mandible, the things that happen while kids are single-digit ages. So if we can identify a 4-year-old whose maxilla isn't growing correctly because they don't swallow right, because they don't breathe right, then know that by the time they're 12, they're going to be an orthodontic mess. What if we can fix it when they're 5? You know, we can make them breathe better and have a better bite.
Yeah, it's powerful. And so many questions. And I'll give them to you as they're coming in. But Deepak, one of our community members, he asked these great questions. Is the U.S. leading the way in airway management, or are there other countries that are ahead? What are your thoughts?
Oh my. Well, let's think about what that means. If we're thinking about adults, then other countries are ahead of us because we in the United States are tied it down to CPAP. If you go to get a diagnosis, then you're going to get a CPAP from most sleep physicians. And the sleep physicians are kind of just zeroed in on that. You know, really interesting, Deepak, is in 21, and just in March, Philips, one of 2 giant companies making CPAPs, produced a very cool infographic for World Sleep Day on March 21st. What they came up with is they interviewed 13,000 adults in 13 countries, so 1,000 per country. And it was scary numbers on some of these things. And a couple of big numbers that popped out is only 18% of the people that are supposed to be using their CPAP were actually using their CPAP. Wow. This was the CPAP company that did the research. 18%. And another big scary number was 32% of the people said, you know what, I'm not even going to go get a diagnosis because I don't want to use a CPAP. So are other countries ahead of us? Yes, because in Scandinavia, you have to go through oral appliance therapy if you're an adult before you even get a CPAP. So you fail first on an oral appliance. And if you are successful there, well, then great, you're done. If then you can go to CPAP. In the United States, it's the reverse. So if 18% of the people are actually using their CPAP, then we're not doing a very good job of addressing adult airways in our country right now.
Yeah. And the problem is just the tip of the iceberg. I mean, we have so many people and good friends. We had Murph on here last week. And, you know, this problem is dentists, and tell me if you agree with this, dentists are better positioned. You know, you're presenting the case for it, but to really change people's lives. Today in the United States, more prescriptions for medication will be prescribed for young kids and in middle schools when nobody's asking enough questions. I mean, parents bring in their kids to the teacher. The teacher says the kid can't focus. They go to the doctor, they write the script, and no one asks good questions. This could possibly change so many people's health and just mental state, mental health state for years to come. Don't you think?
Kirk, I read in the paper this morning, the newspaper. I'm old. I still read the newspaper. And there was an article there about a new drug for ADHD. And it talked in there about the percentage, 30% of kids are getting some kind of medication for ADHD. I was like, oh my God, because why would a child's brain not be ready for the day? Why do they need ADHD medications to get their way through a day with reasonable behavior? It's because they're not sleeping well. There's experts in sleep medicine who tell us this, have told us this for decades. But yet the pattern in the United States is to give kids a pill, give adults a pill too, but give kids a pill for this. But in reality, what we have to do is look at, well, are the kids sleeping well? And the only reason for a child not to sleep well is because they can't breathe well. Now, of course, there are outliers, but if we talk about the majority of children who aren't getting a good day at school, is because they didn't get a good night's sleep. And why can't they do that? Because their structure isn't there to breathe well. So, and dentists have a massive ability to make a difference in that, because there's inadequate diagnosis across the board, but there's really inadequate diagnosis of children. Well, leading up to this meeting on Thursday, of course, I'm having lots of meetings about the meeting. And so we're getting input from all kinds of places. And the sleep physicians who are kids sleep physicians are telling me that, well, you know what? We don't really know how many kids have this problem. Because our colleagues at ADA say, well, we're doing a screener. Well, why? Why are we doing a screener? How many kids have this issue? And nobody has the answer to that because they've done not enough diagnosis. So we add in 163,000 dentists and say 50,000 of them, let's make it a third of them, will actually do something to take care of kids. There's less than 200 pediatric sleep physicians compared to 50,000 maybe dentists who will actually ask parents, how does your child sleep? How do they breathe? What do they do? What are their habits? And we can help make it. What a difference we can make.
Right. Now, after Thursday, and let's go back to the future, because you're privy to a lot of conversations. So after Thursday, let's say I'm a dentist and I'm 32 and I'm watching, and I'm one of the 50,000 that's not. I'm like, Steve, my practice is not equipped for this. I know it's important, but like, help me understand the future-based conversation that's going to happen in dental sleep medicine. How important is it to my future if I have 3 decades of practice in front of me?
Okay, well, so think about this. Think about you hand a parent a 5 questionnaire, 5 questions, and the 5 questions end up with 3 positive answers. Mom's going to say, well, okay, my child has a problem. What do I do? Well, as a dentist, you have a choice. You can become part of the solution right there. You can say, well, let me show you what we do for identifying why your child has positive answers. It's going to be growth and development. It's going to be mouth breathing. It's going to be bad structure. It's going to be tongue tie. It's going to be, there's lots of things. But how does a dentist get to learn about that? There's education in front of them. And this is going to be exciting education. But right now, today, if you as a dentist say, I want to learn about how to help kids, there's not a lot of pathways for that. There's a few. And a couple of them are ASAP pathway. There's 3 passionate dentists who have formulated a great pathway for learning about kids' airway, but it's going to create a ton of demand, because when mom learns that their child has a pathway to breathe better, they're going to say, okay, what do I do? How do I make this happen? Money's not an issue. My child's going to breathe better. If you do something, I'm in. I want to make sure they don't grow up like dad who snores. I mean, all kinds of motivation. There's going to be huge demand by moms. Right. And when moms make demands, professionals listen. So they reach out, got to get educated.
Yeah. Now, and one of the questions that always comes up, we've had great influencers on here like Becca Bacow, and just incredible people that are thinking, how well is the orthodontic world adapted to this? We know a big percentage has, but like from your perspective, what's the conversation between GPs and orthodontists in this respect?
Well, I wish I could agree with you that a big percentage of orthodontics have. And I am so fortunate to have Becca Bacow down the street from me, so I get to work with her daily. But the orthodontic profession is one of our holdouts, and there's huge pressure by young and passionate orthodontists on the leadership there. And so I don't mind that, because they need to change. But the orthodontists are going to lead the charge. The young orthodontists that are paying attention, that really want to make a difference. And by the way, not all young. There's an orthodontist who's not young in Alabama who's one of the leading lights. So anyway, but generally, it's a young generation of orthodontists that are going to say, look, yes, we have the tools. We know about growth and development of the bony structures that surround the airway in 4-year-olds and 5-year-olds. We can make a difference. but they have to break through their standards, break through their long-standing commitment to seeing kids by 7 and treating them when they have their permanent cuspids in. That whole pattern of thinking has to change.
Yeah, absolutely. Yeah. And with the help of Thursday, and again, it's anyone's guess with technology, what we know, and let's be fair to dentistry. Dentistry's always been like slow to just jump on things. I deal with it every day. Dentists constantly say, well, that's the way we've always done it. I don't know. It kind of has to hit a certain number of people and critical success number before people go, oh, this is really working. But what's the future of technology even look like when it comes to DSM?
Well, yeah. Well, first, I want to bring back a point you just made, and that is in a policy statement for the ADA, the second paragraph that talks about kids is helping kids see, or helping families choose evidence-based treatments. Well, we think about what do we have for evidence-based treatments for kids and growth and development and long-term studies and all that. They're kind of sparse. So we have to use our clinical wisdom to make choices about what we can do. And we're recognizing and we're developing metrics so we can see, okay, what's wrong with this maxilla? Why is this growth and development off track? And then we can start to address that with tools we already have in pediatric offices and orthodontic offices. So what's the difference? The difference is in diagnosis, Kirk. And first we're going to screen these kids. And so we identify who's at risk. Now we have to think about how do we find out where the problems actually are. If we think about diagnosing obstructive sleep apnea, the affliction that gets all the adults in trouble, kids don't have as much OSA. They have some, and we have to be cautious of that. But they respond quite differently, and sleep testing for kids is very challenging. One of the things we're going to do with our validation study of our new screener tool is we're going to actually test home sleep apnea tests for kids. So we can see how those new tests run. One of them's a ring on a finger that's pretty powerful. And we think we have good hope for that one, but that hasn't been tested very well yet.
Right.
So we're going to be part of that future as well. But the major thing is not going to be what goes wrong with kids that looks like the same thing that goes wrong with adults. It's going to be what's differently wrong with kids.
Right.
And that's a huge growth thing for dentistry.
Right. Well, let me piggyback on the differently wrong thing. For people, so we have over 38,000 people that watch this on Facebook at certain times, and some of them aren't necessarily in the dental profession. And my grandmother watches it, and she's in her 90s. And if she was to watch this, or anyone would watch this that would care about the next generation of breathers, say, why is children's breathing such a challenge right now? What's the hypothesis around palates? Why are palates different now than they were 30 years ago?
Oh, that's so fun to talk about. When you think about a 4-year-old, now my face is long past being a 4-year-old, but we can talk about what that looks like in little ones. So little ones, if they breathe through their mouth, then what's happening here? Well, mainly their tongue is not in the roof of their mouth if they're breathing through their mouth. And so what happens, the pressure from the cheek kind of pinches in on that upper jaw. If the tongue isn't in the palate to hold back against that pressure from the cheek, the palate becomes narrow. And as the palate becomes narrow, it goes up. And what's above the palate but the nose? So as the palate goes up, the airway in the nose gets smaller. And the middle of the nose, the septum, moves over to one side because it doesn't have enough room. That's called a deviated septum. So we have these distortions in our nasal breathing. Meanwhile, the palate's getting narrower, the jaws are smaller. So there's, in one view, there's just not going to be enough room for teeth later on. But in the bigger picture view, there's not going to be enough room to breathe. So not only do we have now a palate that's becoming misshapen by our own physiology, we also have a lower jaw that's not being held forward. And so it retracts or it doesn't grow big enough. So now we have a small and set back lower jaw. That setback lower jaw carries with it the base of the tongue, which now is backwards too far. And so we have a crowded airway space behind the tongue. Now we have a crowded nose. We have a crowded space behind the tongue. And in between, we have a narrow upper jaw. Well, what sits on the back of the upper jaw? The palate. So if we think about a drape across a window, if we have a drape stretched all the way across the window, it's kind of flat. But we can pull the drape to one side and it bunches up. If we have a narrow airway or narrow maxilla holding the palate at the back, and we squeeze it, narrower than it's supposed to be, the palate, the soft tissue of the palate also bunches up. So now we have a narrow nasal airway. We have a base of tongue that's too close to the back of the airway, so it's small, and we have a bunched up palate. This is not a recipe for breathing success over a lifetime. However, let's think about an alternative. We recognize grandma goes to visit the little kids, the 4-year-olds, and notices that her grandson is breathing only through his mouth. What if she says, wait a minute, that's not right. What do we do about this? Well, the right kind of therapist, it could be dentist, pediatric dentist, myofunctional therapist, lots of people can say, wait, we can help this child breathe better through their nose. And there's ways dentists can do that. We can now intervene on that little soft maxilla, and we can push that maxilla sideways with expanders. We can make more space. We can make that nose bigger. We can stretch that palate out so it's not a bunched up drape anymore. We can stimulate the lower jaw to come forward, so we bring the base of the tongue forward off the back of the throat, all while the child's 4, 5, 6 years old.
Right.
So now we set that child off on a whole new pathway, and the only people that can do that is dentists.
Yeah. Now, again, I'm going to ask this question because if you're not heavily involved in this education, one of the questions might be, well, what's the difference if a kid's breathing through their mouth or nose? There's a huge difference when people process air through those two points. Can you explain that?
It's structure. It's the difference in structure. Now, there's some chemical differences too. We produce a chemical in our sinuses called nitric oxide that helps us process oxygen better in our lungs. But that's not the biggest thing in a 4-year-old. The biggest thing is the fact that the maxilla is a plastic structure at that stage. They're growing. It's moving. It's becoming influenced by these muscle forces. Not true in a 14-year-old or a 44-year-old, but it's absolutely true in a 4-year-old. So we have 1 decade of opportunity from 0 to 9 to make a difference in how these structures grow up. And there's nobody that pays attention to 0 through 9-year-olds better than pediatric dentists, orthodontists, and family dentists. And so that's going to be the group that's going to make the giant differences going forward. Because think a little bit about, getting nice straight teeth and a beautiful smile. It's a wonderful goals. But what we have to think about is, why are those bones there? They're there to hold the teeth, but they're also there to frame the airway.
Right. And Deepak, dude, I'm completely tracking you because this was going to be one of my next questions, but I'll just let him ask it. Any thoughts on historical diets and development or inadequate development on airway structures?
Oh, Kevin Boyd is a pediatric dentist there in Chicago, and Mariana Evans, an orthodontist in Philadelphia area. They're doing a huge project on the growth and development of the face, and they're looking at skulls from way back when. Kevin's taught me so much about this. The other thing that taught me a lot about this is I went to the Safeway here and looked at the children's food aisle, and I found that kids don't eat food anymore. They squeeze food out of bags. And what Kevin's theory is that a few hundred years ago, when we softened our food with cooking and grains and things like this, then we stopped chewing. And then parents apparently get very concerned about the possibility of children choking on eating a carrot. So they give them, smooshed up carrots in a bag. And so the bones and muscles that are designed to chew through things to develop properly are not being asked to do that. So evolutionarily, our structures are too small. Now, can we change that in a 4-year-old in our practice? No, we can't do evolutionary changes. But the nutrition scientists are going to be able to weigh in on this. And someday maybe we look back and realize that, wow, that food in a bag thing was not a good idea. But what families can do today is grow their children with functional work. Everybody understands the value of exercise, but the jaw muscles need to exercise as well. The bones need to exercise. The teeth need to exercise. They don't, and so we give little ones something to chew. Challenging food is what some of the experts say. Robert Lustig's a great writer about this. Give them challenging food, food that makes them work to eat, and not dangerous food, but challenging food. put the muscles and bones and teeth to work the way they're supposed to, and that'll help alleviate quite a bit of this growth and development issue. But because of the influence of epigenetics and all these things, we have to intervene. And the interventions are what we know today to expand the palate, to perform good habits, get the tissues out of the way if they're tongue-tied. Those kind of things are critical things we can do these days.
Yeah. One of the questions comes up is children breastfeeding. Does that develop the palate a little bit more? I mean, what are your thoughts on that? That's one of the conversations that comes up, and not so many kids are going that route anymore. Have you found that to be true?
Yeah, I'm no expert on the epidemiology of breastfeeding, but I do hear that, kids are not being breastfed as much as they used to. And we can't, these days and times, we can't take a position that every child must be breastfeed or else you're a bad mom. That's just not helpful. Right. Now, if you have choices, of course, that's good. And here, the value of breastfeeding is the development of the muscles and swallowing patterns. And if we have a natural nipple in the mouth, then the baby has to push hard against that nipple to get the milk out. That pushing hard develops swallowing habits that carry on through lifetime. It develops a tongue in the roof of the mouth posture that carries on through a lifetime. Artificial nipples just don't do that. And so breastfeeding is better. Now, what that also means is if a child must be fed not through breastfeeding, then the pediatric dentists just need to pay attention. And maybe we need more thorough interventions in the next few years. Right. So it's not a deal killer. Right. But it's really better. Yeah.
And, somebody else that's watching also asked this question, are there any current great textbooks on dental sleep medicine? Now, I'll speak to that. If you haven't seen Steve speak, or if you haven't had Steve to your, study club, you have to. There's great educators out there, but Steve, hopefully after Thursday and the months to come, there's going to be better education around this. Is there a gold standard, like a really well-written or course other than,
other than mine?
Yeah, other than yours. I love yours, but has anyone written the golden standard on this or not?
Yeah, well, I got to say there's two really great books out there. The best one is called Dental Sleep Medicine, or Sleep Medicine for Dentists. Sleep Medicine for Dentists. It's right over there on my bookshelf. Edited by Gilles Levine. It's on its second edition. It's a fantastic book. Tells you all about the science and the medicine part of dental sleep medicine for dentists. And it's short chapters. It's got great information. Then a few years ago, my own horn here, my colleague Ken Burley in Arkansas and I wrote the Clinician's Handbook for Dental Sleep Medicine. Now I got to tell you, it's hard for me to say this, Kirk, but I'm actually starting a 12 episode, 24-week class through the Pankey Institute, where every other Tuesday, we're going to have a session about one of the chapters in the book.
Awesome.
And which is going to be, I'm so looking forward to this. It's going to be tons of fun. But I got the book out and I started reading it for the first time in years. And I actually texted Ken. I said, Ken, when was the last time you read our book? And because, I'm sorry, hard for me to say, but I think we did a pretty good job. And other people have said that too. And so what I'm hoping it is it's super helpful, super valuable for people putting something into place. So you can get that book from ADA Library. You can get it from Great Lakes Dental Technologies, from any bookstore. So Clinician's Handbook for Dental Sleep Medicine is Ken's and my take on how do you put this into practice. And the Dental Sleep Medicine, or Sleep Medicine for Dentists by Levine, is from Elsevier, I think. And so it's another great textbook. Those are the two standard textbooks right now.
Yeah, Steve, you're a very humble man. I've watched you speak. You're an incredible educator. So don't downplay that. You know what you're talking about. So if you're listening, make sure you check that out. Now, our writers will put that link in there. So if you're listening on Spotify or Stitcher or wherever, just flip up to the show notes and you'll see a link to Steve's book and the courses. And then we're going to have you back when you do launch those courses at the Pankey Institute, because I'd love to know more about those.
Yeah. Well, the 12 episode series starts April 20th. So sign up fast. Yeah.
It sounds good. Sounds good.
Something else I want to talk about is diagnosis, because there's a lot in the news, some in the news these days about the American Academy of Sleep Medicine, and they got a couple of other medical organizations together, and they sent a letter to every state dental board. So this affects every dentist in every state of the country. And the letter said that pointed out that dentists shouldn't be ordering or deploying home sleep apnea tests. What the letter it didn't intimate it. It directly stated that dentists are going to be trying to diagnose sleep apnea for adults. That is not what we're trying to do. The AADSM, American Academy of Dental Sleep Medicine, just put out a position paper that says, look, we need to put out some more sleep apnea tests and send the results to the data that's gathered to our sleep medicine colleagues for diagnosis. Exactly the same that we do when we take a cone beam and send it to a radiologist, or a biopsy and send it to a pathologist. So we do a home sleep apnea test, we send the results to the sleep doctor. But the sleep doctors came along and they said they saw that as a threat. So there's a thing going on right now with your state board that says that they may try and restrict you from, or the physicians say that we should be restricted from ordering home sleep apnea tests. Now, if we think back to what Philip said and what the current state of the art is, not enough people, adults even, are getting diagnosed with this disease. Maybe 20% of the people at risk are actually becoming diagnosed. So if we don't become part of the workforce, then the community health is never going to change. When I was being trained in this 20 some odd years ago, they told me that 15 to 20% maybe of the people that were needing to be diagnosed would actually been diagnosed. Still the same number today. The needle has not moved. And 18% of the people that are supposed to use their CPAPs are using it. So we're not making enough difference. The physicians actually need dentists, but they're pushing us away, and I don't understand it. I wish they were doing things differently, but that's the current reality. So what we need us to do as dentists is to reach out to your physician colleagues, your primary care doctors, your ENTs, the sleep physicians you work with, and make sure that they know that, look, we're part of a team. We can't do it by ourselves, but you can't either. And so let's work together and make this happen. But that's current. That's going on right now. And so we're trying to protect the dentist's ability to be part of that workforce by writing letters and testifying to state dental boards and all kinds of things like that to make sure that we can approach this in a reasonable way.
Yeah, I love it. And Deepak's asking, I love the questions he asks. And along that line of communication, what non-dental skills or support can one offer in helping create an airway management center? Because there's a lot of people that see the value in this, but what are your thoughts on that?
Well, here's one, quote, non-dental, unquote, which is nasal breathing. I'm such a nose geek. I love how the nose works. It's a fascinating part of our physiology and our anatomy. Did you realize that the definition of dentistry says that we have responsibility for the oral cavity, the jaw joints? That's things we know about. But the ADA definition also says that we have the ability to impact and pay attention to adjacent and associated structures and their impact on the rest of the human body. What's adjacent to the mouth? The nose. Why is that something that we should pay attention to? Well, it's because as airway-oriented dentists, we can help move the posterior airway open by moving the jaw forward. That's true. But if they can't breathe well through their nose, there's lots of ramifications for that. If we think just about obstructive sleep apnea in adults, if they can't breathe through their nose, well, then they must be a mouth breather. What is that going to do? That's going to increase caries. That's going to increase periodontal disease and inflammation in the mouth. It's going to make them much more likely to have TMD issues, as a matter of fact, if they can't breathe well through their nose because of some ways that the body interprets the airflow. It's fascinating how that works. And if they can't breathe well through their nose, their lung function isn't going to be good enough. They're going to have intermittent hypoxemia. And when the oxygen levels fluctuate up and down because they can't breathe through their nose, then their body hurts and part of their jaws hurt. So we have a mandate, really, as part of our ethics to say, wow, patient, you should be breathing better through your nose. Well, And when we think about mandibular advancement devices, as a matter of fact, let's go back to that and think about how we're going to treat our adults with sleep apnea. We're going to make a mandibular advancement device, a MAD. Some of them are great at keeping the lips together and making nose breathing a habit. Others, you have to use lip tape on. The company that I love teaching for, that they make a tap appliances, and the tap appliances are built to help produce better nose breathers. They have a silicone shield that snaps over the front that makes them nose breathers. You can do a temporary or a professional interim appliance called a MyTap that has a shield over the front that makes them nose breathers. So it really gives us the ability to impact not just oral things, but also nasal things. We have we can help patients with their throat by talking to them about GERD, things that they don't really ever maybe talk to their physician about, or they just hear commercials about. But we can actually be professionals about how acids in the mouth can affect the back of the throat and make their palate not healthy and make the back of their throat not work well. So there's lots of ways we can expand our view past the oral cavity into adjacent and associated structures and their effect on the human body, being very good dentists, being a little bit better doctors, and we can help our patients see a pathway to a preferred future that's not always immediately apparent and certainly not part of our dental school training.
Yeah. And just to reiterate, I mean, dentists are better positioned now to change people's lives, I think, than ever. And it's very exciting. This conversation is happening and we're all pulling for you on Thursday. I know it's going to go really well, but any last thoughts? I want to have you back again and again to give us an update on where this is heading, but we talk about the future of dental sleep medicine. Any last thoughts you have on it?
Well, the future of dental sleep medicine is expanded function for dentists. And for our adult patients, the treatment's pretty stable. I mean, we have CPAPs, we have surgeries, we have some new things, but we have oral appliances. But the future is going to be in identifying more people at risk and getting them diagnosed through simpler means. Right now, you can put a ring on your finger and get a full diagnostic of you can tape a little button to your finger and get a full diagnostic of sleep apnea. So that's no longer going to be the sole province of a sleep lab. It's going to be in every healthcare provider. That's us. So it means we need education about that. One of the things that's really cool is the collaboration efforts. And so I want to say something about the American Academy of Physiologic Medicine and Dentistry and the American Academy of Oral Systemic Health, AAPMD and AOSH. We put together a meeting called Collaboration Cures every year, where we get together with dentists and physicians and functional medicine and physical therapists and myofunctional therapists and speech and language pathologists, and we learn from each other. We're actually going to have an in-person meeting called Collaboration Cures in Atlanta in September, where we're going to have an amazing group of folks talking to us about what we can do to have a big impact on health. So it's those kind of opportunities that we have that will make the difference. So learn from that. Sit down and figure out a way to get your education up on adults, like my series on the book. But also learn about how you can make the biggest difference in the little ones. So pick up an education opportunity from AAPMD. We do webinars every Monday night or every week. And one Monday night is a group of passionate pediatric dentists called Endeavor. And they are leading the charge for creating education for dentists about pediatric airway. ASAP pathway is another one. So we have lots of ways, not lots, we have significant ways, there we go, that dentists can learn more about this. You just have to seek them out at this point, and they're going to become more and more popular as we go forward.
Yeah, absolutely. And so I know you're doing a lot of great courses. So for the benefit of people that are listening, if I want to come to my study club, or if I want to reach out to you, how do I find out more about, who you are, what you do? How do I find you?
Well, currently go to seattlesleepeducation.com. And I apologize for that crappy website. Sorry, guys, but we're working on it. We got big plans. And I'm working with some really talented folks to make this more reality. But seattlesleepeducation.com to find me. seattlesleeped@gmail.com is my email address. I love to get inquiries from people with clinical questions, and we can talk about your patient. I'm happy to help with that. We can talk about coming to your study club or your state meeting, whatever I can do to spread the word. I've been doing that for a long time. I love doing that. And so You know, years ago, you know Gary DeWood very well.
Yes.
And Gary and I were talking about, and I'll never forget this. And we said, okay, Gary, what would we do if, you know, we knew we just had just a little bit of time left. You know, we could do a couple of things, but our time was going to stop in, you know, a few weeks. And Gary, we agreed that what we would do is we'd say, let's find a group and teach them something, you know, because we just, you know, we can't not teach. And so I love doing that. And the reason why people like Gary and Kirk Behrendt and Steve Carstensen love to teach is because we see a better future for our community health. And the better future for our community health comes through educating dentists so they can take their place at the table and make their big difference for their patients' lives. So it boils down to the person in your chair. What are you doing to be your best doctor for them? Are you going to be a great dentist and help their tooth issues? Absolutely, you're going to do that. But what else can you do? What creative ways can you and your team deploy to make sure their lives get better? Not just their teeth. Their teeth are important, but what can you do to make their lives better? And in adults, man, when, like Mark said, when somebody comes back from an oral appliance therapy and they say, I can't believe sleeping is this good. I love my life. That is so heartwarming. When moms come back and say, my son in school is a different kid. The teachers are calling in, what happened? Because they're just doing so much better. You know, it doesn't take very many of those kind of stories to make sure that you're going to have the energy, the time, the money, the resources, the effort to listen to the podcast, to attend the classes, to buy the books, to do all the things that we do as learners, to impact our patients' lives. Dr. Pankey told us this long ago. The rewards come spiritually and financially when you meet the people's needs that come to see you, when you learn about them, when you learn to master your profession, when you apply the knowledge that you have. And those words ring true every day of my life. Keith Thornton started them in C2 all those years ago with airway issues. You know, the Pankey philosophy is just what we do to make our patients' lives better. And that's what we do as a profession. And it's so energizing. I have no trouble getting enough effort to make this happen. And so I'm happy to throw that rock in the pond and watch the ripples roll away.
Amen, brother. And you know, do you have time for one more question? Because you're blowing up the feed on some great questions. Another person watching asked this question. Airway has been integrated into my practice, and frequently patients ask why. The explanation of adjacent and associated structures as written in the ADA code, you know, it is helpful in me articulating more clearly the importance of this to patients. Can you just speak to that real quick?
Sure. Well, one of the things to keep in mind is when we think of all of healthcare, every player in healthcare, who does the patient spend the most time with in an annual basis? It's the dental hygienist, because they have 2 hours or so, maybe more, to impact that patient's health, to communicate the values. When they sit down with their dentist, they have time to ask a question. Do you have time to ask a question of your primary care doctor? Do you have time to ask a question if you go to a specialist? Are they going to be interested in adjacent structures if you're there for their specialty area of medicine? No. We're the generalists. We're going to be the primary care doctors of the future. We're going to do our thing. Now, physicians have different training, and there's lots of things they can do that we can't. So I'm not trying to overstep our bounds, but I'm trying to expand our bounds. So what you do with those adjacent and associated structures and the impact on the rest of the human body, that's what you do when you become a better doctor to go along with your dental skills. Now, again, I'm absolutely not sending a message that our dental skills are unimportant. They're critically important. We're the only ones that can do those procedures. But we expand our thinking into medicine, into what can we be doctors for. And it's a different mindset, because there's lots of things we can talk about because we don't have time for. But really thinking about how your knowledge base can help lead a patient from their current state of health into a preferred future, man, that's powerful and fun.
Yeah, absolutely. There are people that fix teeth and there are people that change lives, and it's not the same business. So,
Right.
buddy, I know we're all pulling for you on Thursday. I know it's going to go
Yeah.
extremely well, and I can't
Yeah.
wait to hear what comes as a result and then what the future looks like. So, I really, really appreciate you. So, if you're listening, I'm going to encourage you to reach out to Steve, follow him and see what he's up to, not only at the Pinky Institute, but also Spirit Education. And it's great, great stuff. So, Steve, thank you so much, my friend. I really appreciate it.
And appreciate what you do, Kirk. You're bringing the best practices, show best people in dentistry talking, and so it's amazing. Thank you for all this.
Hey, it's my pleasure. I have fun doing this every day. So thank you guys for listening and watching to the best practices show. If you enjoyed today, which I know you did, just do me a favor, hit the share button, share with your friends. Keep sending us suggestions for things that you guys want to see on the show, whether it be from Steve or whoever we have in the show, and we will line them up to make sure you guys get the best information and create a better practice and a better life. But until we see you next time or talk to you next time or you hear from us next time, keep watching the Best Practices Show. You guys enjoy the rest of your day.